Hi, welcome everybody. Well, we are the 2011 fellows. We are pleased to welcome the new generation of fellows for this year. We are going to briefly describe the kind of project that we have started and we want to pursue it in the following months. And it is really exciting because we think that they are really valuable, and we are really happy to be part of this consortium. So these are the pictures of all of us. We are going to show basically all of the projects. We are involved in several projects. There are a portfolio of 6 different projects from the last year, and we're going to explain more or less all of them. And I think that one of the collaborators in one of the is going to present. So let me just go through it. One of the exciting projects that we are pursuing is just to improve the safety in high-field MRI imaging. This is a project that involves several large and important groups, both in Boston area and in Madrid. So the medical need for this project is to detect multiple sclerosis earlier, just with higher with 7 Tesla MRIs that are high-end scanners. We are able to detect these plaques that are hardly seen in the current state-of-the-art scanners. So the problem is that going to this high magnetic fields MRI has the potential problem of safety issues because of heat deposition, as I'm going to explain. So you can see that these regions can be seen much better with 70. This has been proved. There has been recent papers showing that it has a high potential for detecting earlier these kind of lesions with these scanners. But as I said, there is a problem. There are safety concerns with these scanners. Why is this? The idea of the magnetic resonance is safe and it has no problems. It is, well, not longer valid, or at least it has to be reviewed with these high magnetic fields resonances. The idea is that there can be some hot spots where the temperature is risen, and there is a potential problem and safety issues. So the problem is that this specific absorption rate is patient-specific. So this is challenging. So the idea is that we are going to individualize the protocol for the acquisition in these scanners based on the characteristics and the anatomy of the patient. We are doing basically a software and hardware approaches to improve this, and also building a library that we are going to use as a reference for these objectives. So we are the fellows with collaboration both in Boston and different groups in Madrid, in Universidad de Juan Carlos, and some PhD students that are also part of the group. Okay, so one of the other exciting projects that we are involved in is about improve molecular imaging with multi-tracer PET. We have called it, because of the M+Visión, M+PET, because it is a multiple and multiplex PET imaging technique. So the idea is to improve the cancer treatment by not only detecting tumors with PET, that is now a really useful technique, but trying to characterize it. Why is it this? So the idea is that the standard now with PET is using FDG to diagnosis and staging. But the problem is that it is not good enough. Why is this? Because tumors are complex. If we only see glucose metabolism, we are only looking at one specific part of it. But there are more things that we would like to know about the tumor, about the blood flow. The perfusion is important for drug delivery. We want to see also hypoxia, the low oxygenation level of most or many tumors. It's important for the prognosis and for the treatment. Radiotherapy works worse if the tumor is hypoxic, and it would be good to know it in advance before the treatment is planned. So basically, we would like to have all this information together when we are thinking about how to treat better the patients. So what is the idea? Okay, so the good news is that all these characteristics can be measured currently with a PET scanner. The problem is that it is not realistic to have a patient one day to have one image, another day, and then to multiply the amount of time that he has to do. PET scanners are being used heavily, and it is not realistic to have all these scans programmed for just one patient. So what we propose is to change this and to enable a new technology that will have the possibility to obtain all these images at the same time in one single scanner. So this is challenging, but we think that it is feasible, and we are taking good results towards this goal. So the idea is to improve the diagnosis with all this multiple imaging, the treatment, and the monitoring. So we are planning to do it, and we are actually obtaining results with hardware, software, and experiments, all of them together with different groups that are collaborating with us, and with the help of the M+Visión Consortium. So this is trying to bridge the gap between Boston and Madrid area and improving the molecular imaging by multiple tracer PET. So thank you.
All right, I'll give the presentation for Team Eye. That's blurry, but it's supposed to be. And our goal is to make eyeglass prescriptions accessible to all. It's Nick, Daryl, myself, and Eduardo working on this. And what we're building is a portable, low-cost device to automatically provide eyeglass prescriptions. There are more than 153 million people who have uncorrected refractive errors. That's a lot of zeros. Most of these are in the rural areas of developing nations. So this is not only a big clinical need, but it's a big humanitarian need. And uncorrected refractive errors can be corrected usually with glasses. So you'd ask, why is this number so big? Glasses are only $4 nowadays in these areas. So even a villager or a rock star can afford these, this piece of health technology. So why is this number so big? And the reason is that there's a need for a low-cost, accessible eye test, because people really can't get the eye test that they need. That's the limiting barrier. For instance, in the US, there's one optometrist for every 6,000 people. But in rural India, there's one optometrist for every 250,000 people, a big disparity. What this amounts to are long waiting lines at rural clinics where they're trying to get seen to get their prescription. And this is basically mirrored by the International Agency for the Prevention of Blindness, where they say cost, poverty, convenience, and accessibility are the big barriers for those seeking care. So to address this problem, what our team wants to do is to increase accessibility by overcoming the trade-off between the training requirements and the cost for devices that are used in ocular exams. So for a device to be really useful in this low-resource setting, it needs to be cheap, fast, and easy to use. That way it's affordable, and many people, more than just trained specialists, can use it. And we're developing a device which we call QuickSee, which we think can do all of this. We started off with an optical design on an optical breadboard, and we've basically been miniaturizing this and using consumer-grade components instead of scientific-grade components to reduce the cost. And now we have a handheld form factor that you can look into, and with the click of the button and waiting a few seconds, you can get you can get your eyeglass prescription. I've used it on myself. We've used it on all the fellows, and we're going to start testing this at the New England College of Optometry pretty soon with real patients. That's the project. We've basically pitched this at the MIT 100K business plan competition, and we're in the finals. We won the emerging markets tract, and we're also right now in the Mass Challenge final venture accelerator competition, and these are our collaborators, and that's Daryl's contact info if you'd like to contact him. This is not my project, but I'll try to give the pitch. This is Nick's project. Daryl, Vicente, and Herman are also working on it, and it's to improve colorectal cancer screening using advanced optical colonoscopy. And these are our collaborators. So colorectal cancer is one of the major cancer killers. It's actually the third. And it's responsible for 1/30 of all deaths in developed countries. So it's a big problem. The way what happens is in your colon, normal cells will mutate, go into adenomas, and over a long time they can become carcinomas. And so because this is a long time for the evolution from the adenoma stage to carcinoma, you'd think if you screened for this, you could detect it early and stop this problem. And that's what's done. There's 14 million exams per year. And the thought was that doing colonoscopies would reduce deaths from colon cancer by 90%. That was what was said in 1990. But there's still a lot of people dying. And actually, if you look at it, the screening only reduces the mortality to 40%. Why is this number so high, right? The reason is when you do an exam, you look at something like this. This is what the gastroenterologist sees when they're looking into the colon. And you can see this is a big tumor. It's pretty easy to see. But the problem is there's other kinds of tumors which are hard to see. You might not be able to see it on this right now. This is another view of it. And this is if you use a dye to enhance the image. And now you can see it. So you'd say, okay, there's a technology that exists to detect these tumors that you're missing. Why is the problem so high? Well, this takes a lot of time to do, and so it's not actually employed by physicians right now. And so what we want to do is to increase effectiveness of cancer screening by decreasing the frequency of these missing these lesions. And we're doing that with optical methods. So Nick and the team are developing novel strategies using only optical methods to extract contrast and make 3D images. It's optical, it has no dye, and it's real time, so it actually does not change the workflow for the physician. That's the important thing. That's why it'll probably be impactful. And so this is a conventional image. This is the kind of 3D image they can reconstruct from that, which is useful for the physician. And this is also what they can do. They can do things like detect height, detect curvature, detect different parameters, which help enhance contrast. This is the fellows working with ex vivo tissue, and this is an actual ex vivo tissue with a tumor, an ulcer in it. And this is the 3D mapping of it. And you might say, okay, I can't really see, but what you can do now is you can do a line profile and look at, quantitatively see where there are differences that your eye might not miss. And you can do this in real time. And this is why this is useful, and if you're interested, contact Nick. And so this is a project that I'm working on with Herman, and we're trying to improve the clinical management of metastatic cancer patients by detecting rare circulating tumor cells. It was briefly mentioned in one of the previous talks. So a need exists to improve the management of metastatic cancer patients. That's pretty obvious, right? You really want to try to detect cancer early, you want to have better diagnosis, and you want to have better monitoring of if a therapy is effective or not. And how do you do this? Well, circulating tumor cells are a potential solution. They're cells that leave a tumor, go through the vasculature, and are thought to be responsible for starting distal metastases. And so if you could detect these things, you could have some sense of how aggressive this tumor is. They're rare because you have to look through 1 billion cells to maybe find one. So it's like finding a needle in a haystack. There are existing technologies to do this. You have like microscopy, you have filters, which just filter cells based off of a size. You have enrichment techniques like microfluidics and immunomagnetic chips to basically try to pull out cells, pull out these rare cells and detect them. But they have problems. Microscopy, you don't have a high throughput, and you need to look through billions of cells to try to find one. And with these other ones, they're actually limited by cell heterogeneity. No two cells are alike, especially with cancer. So if you try to detect them just off of their size, you can miss them, and this is a problem. So what we're trying to do is to improve CTC detection and impact cancer management. So this is an image of just a blood smear on a slide. Doesn't look very good. You're looking at low magnification. But the thing to think about is you see a lot of cells, but you really can't tell what's going on with each cell. You have no real information. If you zoom in, you can maybe see, okay, I see the cell better. I have more understanding of its biomarkers that it's expressing, but you can't see a lot, right? And what we're trying to do is bridge the two. So in one hand, you want a technology that's quick, so you can find rare cells. You can look through many cells at once. And that's kind of analogous to bioinformatic chips, where you're able to search many parameters very quickly. And you want a technology also to be informative. To target the thing you get a hit, you really want to verify, is that a hit or not? So that's kind of where you have high-resolution microscopy. And we're trying to bridge these two. And so what we've done is, this might not look very informative, but these are pseudocells. We're using latex beads that are stained with a certain dye. And we're imaging them at one scale. And we're showing that we can actually detect them at another scale very quickly. And what we think we'll be able to do is to scan many, many cells very quickly and improve the cell throughput analysis for a blood sample and detect these rare cells. And the idea where we got this from is by looking out at the stars. And so we're really trying to reimagine cell analysis. And these are our collaborators. And we're also collaborating with the IE Madrid Venture Lab students to help try to develop commercialization potential. And yeah, if you have any questions, contact us.